Thanks, Tom. I haven't synthesized all of them, you'll be pleased to know. But what I have done, and I've left out pathway because we dealt with that this morning, but what I have done is really put this under 4 topics, brief comments on each topic and some key papers. The first one's already been mentioned, and this came out of the Far Institute at UCL, collaboration between UCL, Queen Mary, and the London School. And it really points to the comment that was made by Owen earlier about the value of registries. And this is from GP registries, over 1 million patients, looking at the outcomes in relation to cause-specific outcomes of 12 different causes, which had never been done before. And actually, the thing that struck me about this data, adjusted for smoking, sex, diabetes, and cholesterol, if you look at cardiovascular outcomes in cardiac terms, and I've used this a lot at the ESC, to convince them that actually this is still a big problem they need to deal with. If you look at this, relationship with stable angina, who would have predicted this? Relationship with unstable angina, myocardial infarction, incredibly powerful relationship with blood pressure. Unheralded coronary disease, heart failure, dramatic relationships. And this is in a contemporary setting of British national healthcare system. And the other clever thing in this paper was the calculation of life years lost to hypertension in the same way as the insurance companies would do this. And this is color-coded. And the color coding, the red refers to diastolic and systolic hypertension, green isolated systolic, and blue diastolic. And you'll see there's very little contribution of diastolic, so most of it is systolic hypertension, either green or red. The other point is if you look at the population risk, then most of it is cardiac. And this is a really important message because although everybody seems to understand that stroke is related to hypertension, I think the message about cardiac disease being very strongly influenced by hypertension has been lost, particularly as many of the other risk factors are now being treated, like smoking and cholesterol. This is going to turn out to be the most important residual risk factor. And this here, these are life years lost, stable angina, unstable angina, myocardial infarction, very powerful. And what we calculated is that over a lifetime from about 40 years of age, if you have hypertension, you'll lose about 5 years of your life. And that's as much as smoking 20 cigarettes a day. And again, very powerful messaging. But the one I like to use in my clinic, when people ask me, how powerful is the treatment, doctor? What is it going to do for me? I think this is what we calculated from this data, that you have the potential to gain a month of life for every year of treatment, assuming treatment reverses the risk, and we've calculated the level to which it would. So that's a powerful message for patients. Take your drugs for a year and you'll live an extra month. And you begin to add that up. And it also tells us the message, the sooner we start, then the greater the benefit that will be accrued. So I thought that was an important thing to start with. I think the potential of using registries to get epidemiological data is going to be very powerful. New drugs. There haven't been many. This is one. The so-called ARNI, the angiotensin receptor neprilysin inhibitor. And this is a review that I thought was a good review, as I'd highlight, in the European Heart Journal. Again, mainly because it was focusing on hypertension rather than heart failure. Actually, this drug looks interesting for hypertension. It's some sort of combination of valsartan and sacubitril being metabolized into a NEP inhibitor. It's not entirely clear to me why this isn't a combination pill, but basically it's being touted as a single molecular entity. Maybe the pharmacologist will be able to explain what the difference is. But basically it's valsartan in combination with sacubitril. And there is a lot of complementarity here. For example, blocking NEP will actually activate the renin system, and therefore it's logical to block it. You'll also get effects of potentiation of natriuretic peptides, which might be beneficial in hypertension, particularly in the context of improving ventricular vascular coupling and de-stiffening the arterial system, which is one of the areas that we approached the manufacturers of this drug to look at and potentially deliver this drug for the treatment of systolic hypertension, where there's still a challenge, I think, in people with stiff arteries. In fact, the data in systolic hypertension from this review looks very impressive. So this is the drug, a study by Relupe, looking at LCZ 696, 400 milligrams a day, which is the top dose currently being used, against valsartan 320, which is the other constituent of this drug, of course. And you see a much more impressive reduction in systolic blood pressure, cardio against placebo, 20 millimeters drop in systolic blood pressure in stage 1-2 hypertension, pretty impressive. And in Paramount, which is in diastolic heart failure, 9 against 2 with the ARB alone, and even on diastolic. But the interesting thing about this drug is it seems to have a greater effect on pulse pressure than most other antihypertensive therapies in direct comparison. So at the ESC, we presented the first study with this drug in systolic hypertension looking at hemodynamics. So we had 2 at that session on hypertension. And this is a simple study that was basically systolic hypertension, increased pulse pressure, so the patients had to have a pulse pressure greater than 60 and systolic hypertension, indicative of arterial aging and stiffening. And we knew that this is a particular risk factor for heart failure where this drug had already been seen to reduce morbidity and mortality by about 30%. And we also knew that large artery stiffening increased central pulse pressure and central systolic pressure. So by measuring these hemodynamic parameters, we'd begin to see whether this might be give us an insight into changes in ventricular vascular coupling. And there's a parallel MRI study being undertaken as well looking at this. So we did a 12-week and then 52-week extension looking at LCZ against olmesartan, which is a very effective angiotensin receptor blocker in older patients with systolic hypertension and increased pulse pressure. A very simple design. The primary outcome was actually the central hemodynamics at 12 weeks when they were on monotherapies with both drugs, although you could argue that the LCZ is in fact a combination pill, and then an extension, which I'm not going to mention here. And the hypothesis was that this would in some way reduce central hemodynamics more effectively, mainly through a de-stiffening effect on the central aorta because of the potentiation of NEP, and that we might see an improvement in natriuretic, having to switch between things, natriuretic peptides. So the primary outcome was central aortic systolic pressure. And this is very much exploratory with a view of going on to outcome trials. Population shown here. So they had, these are the central hemodynamics are at the top. The thing you'll be more familiar with below are the peripheral hemodynamics with systolic hypertension, clear, and 24-hour blood pressures shown here. So the central systolic pressure was significantly lowered more than the, with the LCZ 696 than with olmesartan. And this was true if we look at the per protocol analysis, and also if we look at central pulse pressure. This was also reduced by an additional 50% with this agent. If we look at the changes in brachial, again, we saw more impressive brachial systolic pressure reductions and much more impressive pulse pressure reductions with these patients using brachial pressure. What I was particularly excited about is we used a lot of new kit in this study, and this was one of the, one of the devices we used, 24-hour ambulatory blood pressure, but also 24-hour ambulatory central pressure measured with an oscillometric method. But actually, if we just focus, and the results for both are pretty equivalent, but if we just focus on the brachial pressure, which you'll be more familiar with. So this is olmesartan, and this is this new ARB-NEP inhibitor. The thing that fascinated us was, first of all, the mean change. It was greater, a reduction in 24-hour pressure overall with the LCZ 696. But if you look at the where the change occurred, it was predominantly lowering nighttime pressure more effectively. We've never seen that before with any drug. So this is remarkable, and I think needs looking at in more detail. We may have a drug that is particularly effective at lowering nighttime blood pressure. Might be very relevant to patients with CKD, diabetes, and many of the more severe hypertensives who have nocturnal hypertension. So we're very excited about this result. The other interesting thing is you can look at NT-proBNP and see whether the release of NT-proBNP is an indicator of stress on the ventricle and coupling with the aortic root. And we saw a much more significant reduction in NT-proBNP with LCZ 696. Again, perhaps pointing towards better protection ultimately against heart failure. And my prediction would be that this drug will be effective in diastolic heart failure because of these very impressive effects apparently in uncoupling and de-stiffening. We also have data on pulse wave velocity in the outcome data, which we'll present in the final paper. So this is the first randomized study demonstrating the ability of this drug to affect central hemodynamics in people with systolic hypertension, and it suggests that it might provide beneficial effects which are over and above those that we can get at present with conventional RAS blockade. And whether or not we can convince the company to do a major trial with this drug in hypertension, systolic hypertension, is still perhaps one of the biggest challenges, as they have a unique opportunity to develop this solely for heart failure. I hope they will look at this as an unmet need in hypertension, particularly systolic hypertension, going forward, because I think the profile of this drug looks really impressive on a number of fronts. The other thing, for those interested in central systolic pressure and things, and probably not many of you, but basically this is a very nice study published by some members of the society as part of a collaborative, grouping the data so that if there are studies out there going forward, we now have normalized data on central pressure. So I draw your attention to this paper because I think this will become the sort of gold reference standard for normal values for these parameters when you're looking at these measurements in a variety of other studies. Now, what about denervation? It was mentioned previously by Owen, and I agree with everything he said. This is a publication that appeared in European Heart Journal from Simplicity 3, I guess in the aftermath of Simplicity 3. So you know in this trial, against sham, the primary outcome, at least on efficacy, wasn't significant. There was no difference between the sham and the intervention arm in this study, although the procedure was safe, but things that don't work usually are. The interesting thing here was they really tried to cut and slice the data now to try and get some insights into why there might have been no effect in this randomized controlled trial. One thing they looked at was potential ethnic differences in response. So they pointed out in this paper they seemed to get a response in non-African Americans, but it was the African Americans who messed it up, and seemed to do very well on placebo. Perhaps it was them who started taking their treatment. So that's one thing that's come out of this analysis. The other thing that you'll hear about is looking at numbers of ablations. So surprisingly, when this study was first done by people who'd never done it before, they managed to do it perfectly. But when it was rolled out in a clinical trial, they managed to find people who couldn't do it very well. That's the argument. And they argued that if they looked at the relationship with the number of ablations performed and the blood pressure fall, there appeared to be some sort of relationship. And the other thing was and this was paralleled by a suggestion, at least in those on the highest number of ablations, there was also an effect on heart rate. But when you begin to look at this in a bit more detail and look at the multivariate predictors of blood pressure change in Simplicity Hypertension 3, some interesting things emerge. So you'll notice that the predictors of office systolic blood pressure reduction at 6 months were the baseline office blood pressure. Aldosterone antagonist use, and that was true in both arms of the trial, that if you were prescribed an aldosterone antagonist, you were more likely to respond to the denervation. Perhaps that reflects the fact that the denervation made you more likely to take the drug, and that's why that was seen. The non-African Americans patients receiving RDN had significant greater change in office than those receiving sham. And there were a greater reduction in office, ambulatory, and heart rate were observed with the higher numbers of ablations. So this really has fueled interest in whether, and their conclusion was that post-hoc analysis, although derived from limited patient cohorts, reveal several potential confounders that may partially explain the unexpected blood pressure response in both sham and control arms, sham and RDN arms. And these hypothesis-generating data should inform the design of subsequent research into this kind of technology. And I think the emergence of these multi-contact devices, so instead of having to stand there losing the will to live, trying to do multiple burns on the renal artery, you can simply put the balloon or the cage into the vessel, put your foot on a pedal and burn in a number of sites simultaneously, should standardize the delivery of the energy and hopefully provide an equivocal answer one way or the other, using this information to better design future trials. What about other pills in resistant hypertension? We heard about pathway. One of the interesting things that was published last year, I thought was quite interesting, from Bangalore, so inevitably in a meta-analysis, but this is lipid lowering in patients in the TNT trial. You might not remember the TNT trial, but in the days when people were getting excited about more versus less lipid lowering, this is a high-risk group of patients randomized to either 10 or 80 milligrams of atorvastatin. They decided to go and look at the patients randomized into that trial who had resistant hypertension to see whether there was any added value of going on to a very high-dose statin as well in terms of outcomes. So quite a clever idea, I thought. So patients with resistant hypertension, high risk of CVD, would higher dose statins be of benefit in these patients? So they had 10,000 patients with coronary disease, quite low LDL at baseline, given either 10 or 80 of atorva, and about 1,100 of them had a good, well-characterized definition of resistant hypertension. So what were the benefits of high-dose statin? And their primary outcome of the trial was major cardiovascular events was reduced by 30%. So increasing the dose of statin in this population with an LDL 130 at baseline, with a blood pressure that was still elevated despite 3 drugs, actually dramatically reduced their event rates. And so perhaps not surprising, but again, perhaps re-emphasizing that the treatment of resistant hypertension, because many of these patients are complex with multiple disease, isn't just about getting the right drugs on board for blood pressure, but also thinking about whether or not we can optimize other aspects of cardiovascular disease prevention, and this gives us a clue to where we might go. So let me finish with blood pressure goals. And of course, the big news that predated this meeting last week was the announcement from the National Institute for Health's that they were stopping the SPRINT trial, the systolic pressure intervention trial. I was interested actually by the comment from Richard earlier about the fact that we've invested very large amounts of money into networks in the UK, which I think were very important in galvanizing research across the country. But I agree with him entirely. There's been a disconnect between the objectives of the network now and the objectives of the researchers. And if we could spend some of that money that the NHS now spends on infrastructure for research on trials like this, I think we've demonstrated we can do the trials. We just need the investment to do bigger trials and really make a huge impact on public health. And this is one trial that undoubtedly will have a huge impact on public health, and I'll show you a bit about it, or what I've been able to find about it to finish. Multi-center randomized controlled trial. Sorry about my typing last night. Comparing 2 treatment strategies targeting different systolic blood pressure goals. Less than 140 versus less than 120. Really quite dramatic. Patients had to be over the age of 50, as most patients are, with a baseline blood pressure of at least 130 and evidence of cardiovascular disease, CKD, defined quite liberally as an EGFR less than 60, or a 10-year Framingham risk score of at least 15%, or being aged over 75. So in many ways quite similar to ASCOT, apart from the having baseline cardiovascular disease, the higher cardiovascular risk, being over at a certain age, sort of factors that elevate your risk. And I thought this was really clever. I hope you can see it at the back, but basically to get the people in who were likely to get to the targets, because that's important here. If you could get in if you were 130 to 180, but only on no treatment or 1 drug. In other words, if you're at 180 on 3 drugs, what's the point? You're not going to get below 120 if you get randomized to that arm of the trial. So quite clever. 130 to 170, you could be on up to 2. 130 to 160, you could be on up to 3. But if you were on up to 4 drugs, you really needed to be between 130 and 150. If you were too high on 4 drugs, you weren't going to get to 120. So this doesn't apply to everybody, but it does apply to most. And as we've said, you had to have some other risk factors as well. And they screened 14,600. It took me a long time to find all this data. It's sort of buried away in various places. 10,000 were eligible. 9,300 randomized. I thought that was impressive because, you know, these days we often think about trials in the 20,000s, 30,000. That's not a huge number. Intensive, 4,500 versus standard. And it was done in 102 medical centers in the US and Puerto Rico, about 10,000 patients. And importantly, they've enriched the population and pre-specified analyses in different outcomes. Women, 36%. Black Americans, 30%. People over the age of 75, how will they tolerate a blood pressure goal of 120? So I thought that was very clever. And the people with a history of CVD. People, you might say, well, what about diabetes? Well, people with diabetes and stroke were not included in this trial because it was set up at the same time as ACCORD, or roughly about the same time as ACCORD. So they were already doing a trial in diabetes, and presumably they're already doing a trial in stroke, so they weren't included. And the numbers the interesting thing is, if you look at the literature, they were panicking a bit, because the numbers included in the high-risk groups, that's people with established cardiovascular disease or higher than 15%, actually were lower than they anticipated. So they were a bit worried that this trial would be underpowered. So that puts it into context. Now, what were the outcomes? Well, basically, I can't show you all the final outcomes, but basically, it was the first occurrence of myocardial infarction, acute coronary syndrome, stroke, heart failure, or cardiovascular death. That's the primary outcome from clin.gov. The secondary outcomes are all-cause mortality, decline in renal function, development of end-stage renal disease. But interestingly, there's some really elegant outcomes of secondary nature. Sprint Mind, which is in 640 patients who live near an MRI scanner, which is what it says in the paper. Oh, great. Let me just, right. I lived near an MRI scanner who could have brain structural studies, and they also had detailed cognition, so that's important. Pre-specified groups of interest with enough power to look at CKD, Black Americans, people over the age of 75, and women. And other cardiovascular outcomes included AF, aneurysms, Neil mentioned, total mortality, and some other quite elegant studies looking at cardiac structure, function, stiffness, and everything else. So this is really a really nice study. Now, they had 90% power, and I think it's important in the context of stopping the trial, 90% power to detect a 20% difference in the primary outcome, assuming an event rate of 2.2% in the conventionally treated group. Now, let me just finish by showing you something about the medications, because this isn't all just about the outcomes. In my view, this is also about how to do it, because that's important for doctors. And interestingly, they used a strategy which is very similar to the basis of our guidelines, and in fact many guidelines now, RAS blockers, diuretics, CCBs. But interestingly, if you were randomized to the intensive group, you were recommended to start, this has failed now as well, is recommended to start treatment with combination, either dual or triple. And you could start with a triple in this trial. So again, we will get data on the added value of that. And if you look at their formulary, they recommended everybody should use clothalidone when you need a diuretic. And I talked to Bill Cushman already about this, and he says that they're convinced that's how they got down low. We don't use enough of this drug. They also used a lot of potassium-sparing diuretics, ACE or ARB, amlodipine, and only beta blockers if you had another indication such as heart failure or angina. And there were various other treatments. They had a dedicated formulary, but it was quite liberal at the discretion of doctors. And they saw the patients every month, until you were controlled, with algorithms telling you to up-titrate. So I think this in itself might become a very powerful feature of evidence to drive changes in practice. Just a couple of words about the intensive algorithm. They published an algorithm, and I think this will be on every doctor's wall about how to get to goal. This is how they did it, and you can go and have a look at the design paper. And the intensive one, the less intensive one, the only thing I would add to this is there was a step down part of it at the bottom. You were able to step down if you went too low. So to maintain the separation. Again, I thought that was a clever design feature. So the outcome, incredible when I saw this online. Lower blood pressure goal, systolic blood pressure less than 120. I don't know the absolute values. I've heard it's 119 average. Reduce the rates of cardiovascular events such as heart attack, heart failure, and stroke by almost 1/3. It's just dramatic. And reduce the risk of death, and I'm not sure whether that's all-cause or cardiovascular, by almost 1/4. And that's within the conventional range of targeted blood pressure when you target to 120 versus 140. And I agree with Larry Fine from the NHLBI. Our results provide important evidence that treating blood pressure to a lower goal in older or high-risk patients can be beneficial and yield better health results overall. So I think this has been possibly one of the most exciting years for a long time in hypertension. We've got better characterization of lifetime risk for cause-specific events in a contemporary setting, help us predict power for trials, and cardiac disease is the key attributable risk from hypertension in the modern time. New drugs, ARB, NEP inhibitors. Will we see the development of this for hypertension as a new tool, an additional tool to tackle systolic hypertension? The Pathway Programme has provided new data on the safety and unequivocal efficacy of combination therapy against best initial therapy for individual patients, the optimal treatment of resistant hypertension, and possibly suggesting a new definition for that condition, and the emergence or re-emergence of potassium-sparing diuretics as metabolically friendly options to improve treatment and limit the development of more severe hypertension with their earlier application. There's uncertainty about the place, if any, for device-based therapy in hypertension, and I agree with the comments earlier that the rigors needed in these trials to get them up to the level of confidence and certainty that we see with these excellent drug trials that are now being presented. And I think the new data on optimal systolic blood pressure goals will inform and transform treatment guidelines and patient outcomes, but sadly worsen our control rates overall. Anyway, thank you very much for your attention.